Question 1. Mr. Johnson, a 58-year-old male recently diagnosed with head and neck cancer, has been prescribed complex radiation therapy regimen that involves combination of ARRT and stereotactic radiosurgery. In reviewing his prescription, you notice minor discrepancy in the dose prescription parameters relative to the treatment plan generated by the planning system. The prescription outlines total dose that slightly exceeds established protocol limit, while the treatment plan appears to adhere to established dose constraints for both the target volume and the adjacent organs at risk. Considering the necessity to avoid potential overdose to sensitive structures and to maintain treatment accuracy, what is the most appropriate action for the radiation therapist? A. Immediately proceed with the treatment as the difference is negligible. B. Verify the discrepancy by consulting with the radiation oncologist and medical physicist before proceeding with any treatment modifications. C. Adjust the treatment plan on your own without further consultation to reflect the prescription exactly. D. Document the discrepancy and continue treatment without making corrections. Answer. Correct answer. B. Explanation. The appropriate response is to seek clarification from both the radiation oncologist and the medical physicist. According to clinical practice guidelines and departmental protocols, any discrepancy between the prescription and the treatment plan must be clarified to ensure patient safety. The Joint Commission and OPPM guidelines emphasize interdisciplinary communication and a verification process in treatment, which prevents potential overdosing and misadministration. Option A neglects safety concerns. Option C violates the collaborative nature of treatment planning and may introduce errors. Option D is inappropriate because documenting without resolution does not mitigate risk to the patient. This critical review process and subsequent discussion should ensure adherence to dose constraints and the ARRT principle. Question 2. MS Williams, a 64-year-old patient undergoing radiation therapy for breast cancer, is scheduled for her daily fraction. During the pre-treatment check, you notice that the patient's identification bracelet does not completely match the details on the electronic record, and there is slight mismatch in recorded treatment parameters such as beam energy and field sizes. Given the importance of ensuring accurate patient treatment and avoiding medication or procedure errors, what should you do? A. Proceed with the treatment but report the discrepancy at the end of the day. B. Temporarily ignore the mismatch as it is likely an administrative oversight and verify later. C. Adjust the treatment parameters to match the record in the treatment delivery system. D. Pause the treatment immediately, verify the patient's identity and treatment parameters, and resolve the discrepancies with the radiation oncologist and support team. Answer. Correct answer. D. Explanation. Patient safety is paramount. National patient safety goals and the Joint Commission protocols require absolute verification of patient identity and treatment parameters prior to radiation delivery. In this scenario, pausing treatment to resolve discrepancies by verifying the identification details and treatment parameters is critical. Options A and B disregard immediate safety, while option C risks misalignment with the prescribed regimen. The correct answer, D, ensures adherence to safety guidelines, such as those outlined by the NRC and ACCA, protecting the patient against potential treatment errors. Communication among professionals helps maintain quality assurance and proper documentation. Question 3. Dr. Carter's clinic has recently upgraded its immobilization equipment for treating spinal metastases. Mr. Rodriguez, 72-year-old patient with compromised mobility, requires radiation plan that minimizes movement to precisely target his tumor while sparing healthy tissue. In simulation session, you notice that the immobilization device setup may not fully accommodate his anatomy due to previous surgical alterations in his spinal structure. The device appears marginally misaligned with the contours of his back, raising concerns of reproducibility and accuracy across treatment sessions. Given the need to ensure exact treatment positioning, which of the following steps is most appropriate to address the situation? A. Use the device without modifications since minor discrepancies are acceptable in palliative care settings. B. Document the potential misalignment and proceed with treatment, relying on post-treatment imaging to adjust future sessions. C. Reassess the immobilization technique, consult with the dosimetrist and radiation oncologist, and customize or modify the device setup to ensure reproducible and accurate positioning. D. Delay the treatment until a completely different immobilization device can be procured. Answer. Correct answer. C. Explanation. The accurate and reproducible positioning of patients is a cornerstone of modern radiation therapy. Immobilization errors can result in significant deviations in dose delivery to both the target volume and adjacent normal tissues. Regulations from the OPUM and guidelines from the American College of Radiology stress the importance of verifying that immobilization devices are appropriately customized to the unique anatomy. Option A disregards the critical need for reproducibility. Option B relies on retrospective corrections. And Option D unnecessarily delays therapy without exploring possible modifications. Option C not only adheres to established best practices but also emphasizes interdisciplinary collaboration to ensure optimal patient safety and treatment accuracy. Question 4. During a routine treatment session, Istali, a 55-year-old patient with prostate cancer, is prepared for his daily radiation treatment. While setting up the linear accelerator, you notice an abnormal fluctuation in the gantry rotation speed. This fluctuation, although minor, raises concerns regarding the uniformity of radiation delivery across the treatment field. The treatment plan is based on precise beam shaping and field arrangement, optimized dose distribution, recognizing the importance of delivering radiation within strict tolerance levels. What is your next best step? A. Ignore the fluctuation if it appears to be within acceptable ranges. B. Immediately hold the treatment session and perform complete quality assurance check on the linear accelerator involving both the maintenance team and the medical physicist. C. Complete the treatment session as scheduled and plan for service call later that day. D. Adjust the treatment parameters on the fly to compensate for the fluctuation. Answer. Correct answer. B. Explanation. Operating a linear accelerator requires adherence to stringent quality assurance protocols and manufacturer recommended tolerance limits. The small fluctuation in the gantry rotation speed may indicate underlying mechanical or electronic issues that could affect the dose distribution. Professional guidelines, such as those provided by the OPUM and require the immediate investigation of any anomalies. Option A is hazardous, C delays resolution, and D violates the principle of not making unsanctioned on-the-fly modifications. Option B reflects proper protocol by ensuring the machine is thoroughly assessed with input from experts, thereby minimizing risks of overdose or underdose, ensuring both safe and effective treatment delivery and upholding regulatory compliance. Question 5. In an advanced planning session for a patient with a brain tumor MS, Thompson, a 47-year-old patient, is scheduled to receive treatment using VMAP. The treatment plan includes complex isodose distributions to maximize tumor control while safeguarding critical brain structures. During the plan review session, you identify that the high-dose gradient near the optic nerve is less steep than expected, potentially risking damage to the sensory tissue. This raises critical question about the adjustment of beam angles and modulation parameters. How would you address the manipulation of isodose curves in this scenario to ensure both adequate coverage of the tumor and protection of the optic nerve? A. Reassess the beam configuration, modify dose constraints, and potentially incorporate additional imaging modalities to refine the high-dose region while considering patient-specific anatomy. B. Maintain the current plan, trusting that minor variations in isodose gradients will not affect clinical outcomes. C. Increase the overall dose uniformly to compensate for the gradient discrepancy. D. Reduce the treatment dose substantially to prioritize the sparing of healthy tissue. Answer. Correct answer. A. Explanation. This scenario emphasizes the importance of precise dose sculpting in stereotactic and complex treatments such as VMAP. Clinical guidelines and radiobiological principles stress that reconfiguration of beam angles, modulation parameters, and dose constraints is necessary when the high-dose region encroaches upon critical structures like the optic nerve. Option A follows best practices by involving reassessment of the beam configuration alongside multidisciplinary input and possibly further imaging, such as MRI, to ensure optimal adaptation of the isodose distribution. Options B, C, and D fail to address the core issue. Targeted adjustment that offers both tumor control and maximum protection for sensitive tissues. This aligns with recommendations from the OPUM task group reports and ICRU guidelines regarding isodose analysis and adjustment. Question 6. Dr. Kim, a renowned radiation oncologist, has recently introduced a new brachytherapy program for the treatment of cervical cancer at her clinic, NS. Alvarez, a 50-year-old patient, is scheduled for intracavitary brachytherapy. During the treatment planning process, it is noted that the applicator insertion technique might not fully account for potential variations in the patient's anatomy, raising concerns about dose inhomogeneity and the possibility of overexposure to adjacent healthy tissue. With the complexity of brachytherapy in mind and considering the characteristics of different radioactive sources, what is the appropriate course of action to ensure treatment accuracy and safety for MS? Alvarez. A. Proceed with the standard insertion protocol without modifications. B. Adjust the treatment plan solely based on an educated guess about anatomical variations. C. Delay treatment to procure new applicators, assuming all devices are insufficient. D. Review the insertion technique in collaboration with brachytherapy specialist and medical physicist. Adjust the applicator positioning as needed and verify the dose distribution with update treatment planning software and imaging. Answer. Correct answer, D. Explanation. Brachytherapy requires precise applicator placement to achieve the desired dose distribution while minimizing exposure to adjacent organs. Relevant guidelines from the American Brachytherapy Society, along with OPAM recommendations, dictate that any potential misalignment or anatomical variation needs to be carefully reviewed and corrected with input from specialized experts. Option D ensures that interdisciplinary collaboration is leveraged to adjust the applicator's positioning, utilizing imaging and advanced treatment planning software to verify the corrected dose distribution. Options A and B compromise patient safety, while option C unnecessarily delays treatment without exploring feasible corrective measures. This approach mitigates risks of dose inhomogeneity and aligns with contemporary best practices in brachytherapy. Question 7. Mr. Patel, a 60-year-old patient receiving palliative radiation therapy for metastatic lung lesions, is scheduled for procedure that requires close interaction between the treatment team and the patient over an extended period. During the setup, you observe that although the treatment room is equipped with standard shielding devices, there is slight lapse in ensuring that all transient scatter sources are adequately minimized near the control area. With regulations such as NRC guidelines and the ARRT as low as reasonably achievable principle in mind, what should be your course of action to optimize radiation safety for both the patient and staff? A. Trust the existing room shielding and focus solely on the patient's comfort. B. Increase the treatment dose slightly to compensate for any scatter losses. C. Conduct an immediate radiation survey of the treatment area, adjust shielding and room setup as necessary, and reinforce the ARRT protocols through proper team communication and documentation. D. Continue with treatment while scheduling shielding evaluation for the following week. Answer. Correct answer, C. Explanation. The ARRT principle is central to radiation safety and mandates that all exposures be kept as low as reasonably achievable. In this scenario, the slight deficiency in shielding and potential scatter sources demands immediate rectification. Option C incorporates performing a radiation survey, adjusting shielding, and reinforcing proper communication. All actions recommended by NRC and state regulations to reduce unnecessary exposures. Options A and D ignore immediate safety concerns, and option B is counterintuitive, as increasing the dose is not an acceptable solution. This approach ensures both patient and staff safety while meeting regulatory requirements and best practices in radiation therapy. Question 8. Optin-UN is developing an adaptive radiation therapy plan for a 65-year-old patient with recurrent abdominal tumor. The plan integrates CT-MRI and PET imaging data to optimize tumor targeting and minimize exposure to adjacent organs. During the planning phase, it becomes evident that slight discrepancies exist between the imaging modalities regarding tumor boundaries. This raises an essential question on how best to integrate multimodality imaging data to ensure accurate target delineation, especially when anatomical changes may occur between imaging sessions. Which of the following strategies most effectively addresses the challenge while adhering to clinical guidelines and best practices? A. Prioritize the imaging modality that provides the highest resolution and disregard the others. B. Create composite image by overlaying each imaging modality without weighted approach. C. Use advanced image fusion techniques that incorporate registration algorithms and weight imaging modalities according to their respective accuracy and soft tissue contrast in close consultation with radiologists and dosimetrists. D. Delay treatment. New imaging can be acquired under identical conditions. Answer. Correct answer, A. Explanation. Note, Please see correction below regarding the correct answer choice and explanation. After careful re-evaluation, the correct answer for this question is actually C. Advanced image fusion techniques are crucial for integrating multimodality imaging data. Registration algorithms help align the images precisely and weighting each modality based on its strengths, e.g., soft tissue contrast in MRI versus metabolic activity in PET provides a robust target delineation. This strategy is endorsed by guidelines from OPAM, ICRU, and relevant consensus panels. Option A is inappropriate because relying solely on one modality may result in missing important diagnostic details available from other scans. Option B lacks methodological rigor, and option D unnecessarily delays treatment. Interdisciplinary collaboration is essential for leveraging the full benefits of integrated imaging. Question 9. MS. Garcia, a 52-year-old patient undergoing prolonged course of IMT for head and neck cancer, has experienced early signs of mucositis and skin irritation. Her treatment plan includes precise dose constraints to minimize these side effects. However, anatomical and physiological changes during the treatment course are causing unanticipated variations in tissue response. As radiation therapist, you must decide whether to modify treatment approach to mitigate these side effects while ensuring that the tumor receives an effective dose. What is the most effective strategy in this scenario? A. Maintain the original treatment plan and increase supportive care measures without altering therapy. B. Reevaluate the treatment plan with multidisciplinary team. Consider adaptive planning to modify dose distributions and involve supportive care and nutritional services proactively to manage side effects. C. Halt treatment immediately to allow for tissue recovery, irrespective of the treatment schedule. D. Switch to palliative dosing without consulting the oncologist. Answer. Correct answer, B. Explanation. Managing side effects in radiation therapy involves a delicate balance between delivering an effective dose and minimizing patient toxicity. The best approach is to reevaluate and potentially adapt the treatment plan by leveraging multidisciplinary team that includes dosimetrists, oncologists, nutritionists, and supportive care experts. Option B. Adheres to best practices by enabling an adaptive planning process that adjusts to anatomical changes while actively managing side effects. Options A and D fail to address the evolving clinical scenario comprehensively, and option C unnecessarily interrupts the treatment course. Clinical guidelines by the Radiation Therapy Oncology Group, ARRT, and similar bodies advocate for adaptive therapy approaches to optimize patient outcomes and quality of life. Question 10. Mr. Daniels, a 68-year-old patient undergoing radiation therapy for lung cancer, is scheduled for new phase of treatment after review of his treatment plan. Recent imaging has revealed subtle anatomical shifts due to tumor shrinkage and weight loss. During comprehensive plan evaluation, you observe that the originally designed dose distribution no longer optimally covers the target volume while adequately sparing the surrounding organs at risk. Given this scenario, what should be the next step for the radiation oncology team to ensure the treatment plan remains both effective and safe while following regulatory and clinical guidelines? A. Continue with the existing plan to avoid any unexpected changes in dose delivery. B. Modify only the beam angles while keeping the dose constraints and change. C. Implement minor adjustment in the patient immobilization device without revisiting the entire treatment plan. D. Initiate full adaptive treatment planning process with resimulation, recontouring of the target and organs at risk, and adjust the dose distribution accordingly, involving both the dosimetrist and radiation oncologist. Answer. Correct answer, D. Explanation. As tumors respond to treatment, anatomical changes are common, and adaptive radiation therapy is a critical component of modern practice. When imaging reveals significant shifts as described in this scenario, it is essential to resimulate and recontour the target and critical structures to ensure that the new treatment plan reflects the patient's current anatomy. Regulatory guidelines from the OPAM and CLIN protocols recommend a complete adaptive planning process to adjust for anatomical changes, ensuring the dose is delivered safely and effectively. Options A, B, and C are insufficient and risk compromising treatment efficacy or increasing toxicity. The correct approach, D, maintains optimal patient safety and adheres to both clinical and regulatory standards for adaptive radiation therapy. Question 11. Dr. Ramirez's department is implementing new protocol for pre-treatment quality assurance checks. Mr. Edwards, 63-year-old patient scheduled for high-precision stereotactic body radiation therapy (SERT) session requires an extensive CAR process due to the steep dose gradients involved. On the day of treatment, during final pre-treatment CAR check, you notice an unexpected inconsistency between the measured beam output and the baseline values recorded during commissioning. This anomaly is small in magnitude, yet it can have significant clinical impact because of the high dose per fraction used in SRT. The situation poses the challenge of balancing efficient patient throughput with the absolute necessity for treatment accuracy and safety. Which of the following actions best aligns with departmental protocols and regulatory guidelines, e.g., OPAM and NRC, in ensuring that the inconsistency does not compromise patient care? A. Continue with the treatment session, as small fluctuations in beam output are common and acceptable. B. Document the anomaly in the CAR log and notify the clinical supervisor after the treatment is complete. C. Immediately halt the treatment, escalate the issue to the medical physicist and quality assurance team for further evaluation, and only proceed after re-verification of the beam parameters. D. Adjust the treatment plan on the fly, compensate for the variation and continue with the delivery. Answer. Correct answer. C. Explanation. Pre-treatment CAR is essential for patient safety, particularly in high-dose per fraction regimens such as SAR-T. The OPAM guidelines stress that any deviation from established beam output parameters must be investigated immediately. In this scenario, option C is correct because it mandates an interruption of the treatment, consultation with the medical physicist, and thorough re-evaluation of the beam parameters in adherence to safety protocols and preventing inadvertent misadministration of dose. Option A underestimates the significance of the deviation. Option B delays the response and jeopardizes patient safety. And option D is not acceptable due to the risk of introducing further errors without proper validation. Question 12. MS Hamilton, a 59-year-old patient receiving radiation therapy for lung cancer, is scheduled for her daily treatment session. The treatment plan requires highly precise positioning to ensure that the beam is accurately targeted at the tumor while sparing critical structures. During the daily setup, the use of surface imaging and image-guided radiation therapy (ARRT) reveals slight deviation from the planned position. Although the deviation appears minor, cumulative effect over multiple fractions could lead to significant dose errors. Under these circumstances, which of the following responses best reflects the current best practices and guidelines for patient positioning in radiation therapy as recommended by ARRT protocols and the OPAM? A. Maintain the current setup and assume that subsequent fractions will automatically adjust for the deviation. B. Reposition MS Hamilton immediately using ARRT guidance to ensure the treatment plan is correctly implemented before continuing with the treatment session. C. Document the deviation as minor error and treat the patient, trusting that the treatment planning margins will cover the discrepancy. D. Postpone the treatment session and send them home, scheduling review for the following week. Answer. Correct answer. B. Explanation. Accurate patient positioning is fundamental to delivering the prescribed dose to the target while sparing healthy tissue. ARRT protocols and OPAM guidelines clearly support immediate corrective action when deviations are detected, even if minor, to prevent the propagation of dosimetric errors over multiple sessions. Option B is correct because it emphasizes immediate repositioning guided by imaging. Option A assumes that deviations will self-correct. Option C risks underdosing or overdosing the target or normal tissues. And option D disrupts the treatment schedule unnecessarily. Consistency in positioning ensures treatment efficacy and minimizes toxicity. Question 13. Istakata, a 47-year-old patient scheduled for complex intensity modulated radiation therapy (IMIT) regimen, presents unique challenge during the verification of treatment delivery documentation. During the final review process, you identify potential confusion between prescribed doses recorded in gray (GI) and doses that some components of the treatment plan seem to suggest in equivalent biologically effective units. Because of the risk of misconversion, it is crucial to ensure that both the clinical team and medical physicists are in complete agreement regarding the values being administered. Which of the following steps best aligns with institutional and regulatory guidelines for addressing this unit discrepancy before treatment delivery? A. Accept the recorded value and assume that the conversion factors are applied elsewhere in the process. B. Alter the documented dose in the electronic record to align with your interpretation of the conversion factors. C. Initiate treatment as planned, but document your concerns to discuss at the next departmental meeting. D. Pause the treatment process, convene consultation with the medical physics team to verify the conversion and accuracy of the recorded values and update the treatment documentation as needed. Answer. Correct answer, D. Explanation. Correct dose documentation is essential for patient safety and treatment efficacy. The incident described calls for a systematic review and resolution to prevent any misadministration of dose. Regulatory requirements and institutional protocols mandate immediate resolution of such discrepancies before treatment initiation. Option D is correct as it outlines the necessary steps, halting the process, consulting with experts, and ensuring that the treatment documentation reflects the correct conversion from GI to any biologically effective dose metrics. Options A, B, and C each present risks for miscommunication and error propagation, which violates the standards set by the NRC and OPPM for radiation dose accuracy and safety. Question 14. In a complex treatment scenario for Esther Simmons, a 66-year-old patient receiving external beam radiation therapy for thoracic tumor, the clinical team encountered a situation in which the distance from the radiation source to the patient's skin surface was inadvertently modified due to an adjustment in the treatment couch height. This change raised questions regarding how the inverse square law would affect the dose rate received by the patient. Detailed understanding of the inverse square law, which states that the intensity of radiation decreases with the square of the distance from the source. Determine how this alteration impacts the treatment delivery. Which of the following actions best explains the correct application of the inverse square law in adjusting the treatment parameters? A. Recognize that any change in distance has no measurable impact on dose distribution and proceed as planned. B. Quantitatively recalculate the expected dose rate at the altered distance using the inverse square law. Adjust the treatment parameters accordingly and confirm these adjustments with additional dosimetric measurements. C. Increase the exposure time to compensate for any possible decrease in dose, regardless of the specifics of the measured distance. D. Assume that the treatment planning system automatically accounts for such distance variations and make no further modifications. Answer. Correct answer. B. Explanation. The inverse square law is fundamental in radiation physics and is critical to understanding how distance influences dose delivery. In this scenario, any change in distance from the radiation source to the patient can cause significant variations in dose intensity. Option B is correct because it mandates a quantitative reassessment of the dose rate based on the new distance and requires a corresponding adjustment in treatment parameters. This approach is consistent with rigorous dosimetric protocols and guidelines from organizations like the OPPM. Options A and D underestimate the impact of distance variation, while option C lacks a calculated basis for the adjustment, potentially leading to overcompensation or underdosing. Question 15. MS Patel, a 53-year-old patient undergoing regimen of hypofractionated radiation therapy for pelvic malignancy, presents an opportunity to apply the linear quadratic, or Q, model, tool used to predict the biological effect of different radiation doses and fractionation schemes. During review of her treatment plan, you discover that the chosen fractionation schedule may not optimally balance tumor control with normal toxicity according to the LQ model parameters. Given the complexities of radiobiological responses in hypofractionated treatments, which of the following actions is most appropriate to ensure the therapeutic ratio is optimized for MS? Patel's treatment. A. Ignore the potential imbalance because hypofractionation generally results in better tumor control regardless of LQ predictions. B. Immediately reduce the dose per fraction as precaution without consulting the oncologist. C. Reassess the treatment plan in collaboration with the radiation oncologist and medical physicist. Apply the LQ model to predict biological effective doses, bed, and adjust the fractionation schedule accordingly. Optimize the treatment balance. D. Continue with the original plan and plan to perform post-treatment retrospective analysis. Answer. Correct answer. C. Explanation. The linear quadratic model is integral to modern radiotherapy planning, especially in hypofractionated regimens where both tumor control and normal tissue toxicity must be balanced meticulously. Option C is correct because it emphasizes the need for a collaborative reassessment of the fractionation schedule using the LQ model to calculate the biological effective dose. This proactive approach aligns with evidence-based practices and guidelines from professional bodies like OPPM and ASTRA. Options A, B and D either disregard the scientific basis of the LQ model or do not provide an adequate collaborative solution to the potential issue. Question 16. Dr. Monroe is tasked with designing an IMRT plan for Esther Jenkins, a 61-year-old patient with an irregularly shaped tumor adjacent to critical structures. During the planning phase, you observe that the current beam arrangement results in suboptimal dose distribution, increasing the risk of excessive exposure to nearby organs at risk. In response, the planning team debates the merits of reoptimizing the beam angles and incorporating multi-leaf collimator (MLC) configurations to better conform the high-dose region to the tumor contour. With respect to international dosimetric guidelines and the principles of beam shaping, what is the most appropriate modification to optimize the plan? A. Reassess the beam configuration by incorporating advanced MLC modulation and carefully evaluating alternative beam angles in collaboration with the dosimetrist, ensuring the target is adequately covered while minimizing exposure to critical structures. B. Retain the current setup and only adjust the total treatment dose upward to compensate for dose fall-off. C. Switch entirely to 3-conformal therapy without further attempt at optimization. D. Dismiss the potential benefits of plan modification, assuming that the available setup already meets minimal clinical requirements. Answer. Correct answer A. Explanation. Beam shaping and field arrangement are crucial to delivering a highly conformal dose in modern radiation therapy. In this case, option A is the best approach because it recommends a thorough reassessment of the beam configuration with advanced MLC modulation and a collaborative review of beam angles. This modification adheres to contemporary standards and guidelines from the OPAM and ICRU, which stress that target coverage and organ sparing must be achieved through individualized planning adjustments. Options B, C, and D fail to address the root problem and may compromise treatment efficacy and patient safety. Question 17. MS Lee, a 70-year-old patient treated for recurrent head and neck malignancy, is undergoing multi-fraction radiation therapy regimen. Given the complexity of her treatment, it is absolutely critical that each fraction is documented with precise details regarding dose, beam orientation, patient positioning, and any adjustments made throughout the course of therapy. During routine audit, you discover several ambiguities and incomplete entries in electronic treatment records, which may have significant medico-legal implications and affect the evaluation of treatment outcomes. In this scenario, which action best addresses the necessity for comprehensive documentation in compliance with regulatory requirements and professional standards? A. Continue with treatment as is while planning to update the records at the conclusion of the treatment cycle. B. Rely on verbal communication among the team in lieu of detailed electronic documentation, assuming that everyone is aware of the adjustments made. C. Immediately correct and update the treatment records, ensure that all team members are trained on proper documentation protocols, and implement periodic audits to maintain compliance with standards outlined by regulatory agencies and accrediting bodies. D. Abandon the current electronic system in favor of handwritten records for this patient only. Answer. Correct answer C. Explanation. Accurate documentation is a cornerstone of radiation therapy practice and is essential for both patient safety and legal accountability. Option C is correct as it not only addresses the immediate need to update the records, but also emphasizes ongoing education and systematic audits to ensure adherence to standards set by accrediting bodies and regulatory guidelines, such as those from the Joint Commission and state regulations. Options A and B are unacceptable due to the risk they pose for compromising accurate treatment records, while option D is not a sustainable or compliant solution in modern clinical practice. Question 18. Dr. Chen is planning a complex treatment for Esther Roberts, a 55-year-old patient with deep-seated abdominal tumor. The treatment planning process leverages multimodality imaging, including ET-MRI and PET scans, to achieve precise delineation of the tumor and the surrounding organs at risk. During the image fusion process, slight misregistrations among the different imaging modalities raise concerns about the accuracy of the contouring. To address these discrepancies, the clinical team must decide on the best method to integrate the imaging datasets and ensure precise planning. Which of the following strategies is most consistent with evidence-based recommendations and best practices in advanced treatment planning? A. Rely exclusively on the CT images since they provide the primary anatomical detail necessary for planning. B. Use the MRI images alone for planning, given their superior soft tissue contrast, and discard the other modalities. C. Generate composite image by overlaying the scans without employing any specialized registration algorithms, assuming that minor misregistrations are clinically insignificant. D. Utilize advanced fusion techniques that incorporate robust registration algorithms and weighted integration of each modality, consulting with radiologists and dosimetrists to achieve precise target delineation. Answer. Correct answer. D. Explanation. Multimodality imaging is integral to enhancing the accuracy of treatment planning, especially in complex anatomical regions. Option D. Reflects the current best practice by recommending the use of advanced image fusion and registration techniques. This strategy ensures that the strengths of each imaging modality are fully leveraged while minimizing the risk of misregistration errors. Options A and B overlook the complementary information offered by each modality, and option C is too rudimentary given the potential for clinically significant errors. Guidelines from the OPAM, ICRU, and various radiological societies support the use of sophisticated fusion techniques as detailed in option D. Question 19. Esther Foster, a 68-year-old patient receiving long-course conformal radiation therapy for esophageal cancer, has experienced significant weight loss and anatomical alterations over the course of his treatment. These changes have led to shift in the relative positions of the tumor and surrounding organs. In the latest planning review, you realize that the original treatment plan may no longer adequately cover the target volume or spare the structures, necessitating an urgent decision. What is the most appropriate action in light of institutional guidelines and adaptive radiation therapy practices? A. Maintain the original treatment plan to avoid treatment interruption, trusting that the planning margins provide sufficient coverage. B. Immediately re-verify the patient's anatomical changes with updated imaging and modify the treatment plan accordingly by recontouring the target and organs at risk, engaging the entire treatment team in the decision-making process. C. Adjust only the patient's immobilization device, assuming that repositioning can compensate for the anatomical differences. D. Document the changes and schedule review session after completing the remaining fractions without making immediate modifications to the plan. Answer. Correct answer. B. Explanation. Anatomical changes during radiation therapy can have a profound impact on dose distribution and treatment efficacy. Option B is correct as it advocates for a prompt and comprehensive reassessment using updated imaging, recontouring, and plan modification. Such adaptive strategies are strongly recommended by clinical guidelines from organizations like the OPAM and ASTRO. Options A, C, and D fail to adequately address the potential risk of geographic miss or unintended overdosing of healthy tissues. An immediate and interdisciplinary response is essential to maintain the delicate balance between effective tumor control and normal tissue sparing. Question 20. Dr. Brooks is overseeing an adaptive radiation therapy program for Ines Rivera, a 62-year-old patient with locally advanced head and neck malignancy. Over the treatment course MS, Rivera experiences notable changes in tumor size and patient anatomy due to both tumor response and weight loss. These alterations necessitate the periodic re-evaluation of the treatment plan to ensure that the planned dose continues to conform to the target volume while protecting critical structures. Given these dynamic circumstances, which of the following strategies best exemplifies the principles of ADAPT? Radiation therapy, ensuring that the treatment remains both effective and safe. Immediately initiate complete adaptive replanning process that includes resimulation, recontouring, and adjustment of the dose distribution with close interdisciplinary collaboration among the radiation oncologist, dosimetrist, and medical physicist. B. Continue with the original plan until the treatment concludes and then perform retrospective review. C. Make only minor adjustments to the beam angles based on pre-treatment without full replanning process. D. Temporarily suspend treatment while MS. Rivera undergoes an extensive diagnostic workup before continuing with the current plan. Answer. Correct answer. A. Explanation. Adaptive radiation therapy is designed to account for the dynamic nature of patient anatomy and tumor response during a treatment course. Option A is correct because it involves a comprehensive replanning process with updated imaging, recontouring, and dose distribution adjustment. This approach is supported by current guidelines from professional organizations such as the OPM and ensures that treatment continues to be both effective in targeting the tumor and protective of critical normal tissues. Options B, C, and D do not provide an adequate response to significant anatomical changes, potentially compromising therapeutic outcomes. Immediate interdisciplinary action is essential to maintain precision in adaptive therapy. Question 21. In a busy brachytherapy suite, Dr. Sanders is preparing to treat Esther Caldwell, a 62-year-old patient with prostate cancer, using sealed radioactive source. During pre-treatment verification, you are responsible for ensuring that the source's activity is accurate and that the decay calculations have been updated correctly based on the half-life characteristics. Esther Caldwell's treatment plan is critically dependent on precise source strength and the correct estimation of the radioactive decay over the treatment period. You notice that the documentation provided appears to be based on outdated decay data, potentially affecting the dose delivered over the course of the fractions. Given the strict adherence to guidelines from the NRC and the OPM regarding source calibration and decay corrections, what is the most appropriate action to take before proceeding with the treatment? A. Proceed with the treatment as scheduled, assuming that any minor discrepancies are within acceptable limits. B. Adjust the treatment time manually to compensate for possible decay errors without verification. C. Continue with the treatment but document the discrepancy for future review. D. Immediately pause the treatment process, verify the updated decay parameters with the medical physicist, and recalibrate the source activity according to standards. Answer. Correct answer, D. Explanation. Accurate knowledge of the radioactive decay and source calibration is paramount in brachytherapy, as even small deviations in activity can lead to significant dose errors. Guidelines from the NRC and OPM require that any discrepancies in decay data be addressed immediately through recalibration and consultation with the medical physics team. Option D upholds patient safety and regulatory compliance by ensuring that the treatment is delivered with accurate and current data. Options A, B, and C pose risks by either assuming acceptability or failing to verify and could lead to improper dose administration. Question 22. MS. Green, a 55-year-old patient with lung cancer, is scheduled for critical intensity modulated radiation therapy IMID session. Dr. Patel's department has recently implemented enhanced pretreatment quality assurance (CAR) protocols designed to catch even minor discrepancies in equipment performance. During the daily CAR check, you observe slight inconsistencies in the dosimetric output of the linear accelerator, which might affect the delivered dose accuracy over the high number of fractions prescribed. The departmental CAR protocol, in conjunction with guidelines provided by OPM, underscores the importance of resolving any equipment discrepancies before patient treatment. In this situation, what is the most appropriate course of action to ensure both safety and accuracy? A. Halt the treatment immediately. Conduct detailed care reassessment with the medical physicist and resolve any discrepancies before proceeding. B. Document the issue and proceed with treatment, planning to address the problem at the next scheduled maintenance check. C. Briefly adjust the dose parameters on the fly without full CAR evaluation and monitor the patient closely. D. Continue treatment under the assumption that the deviation is within acceptable tolerance levels. Answer. Correct answer. A. Explanation. High-precision therapies such as IMID demand rigorous pre-treatment CAR to ensure the integrity of dose delivery in accordance with OPM and guidelines. Any inconsistency in dosimetric output must be addressed immediately. Option A correctly advises pausing treatment, performing detailed CAR check with the medical physics team, and resolving the issue prior to patient treatment. Options B, C, and D risk compromising treatment safety and may result in dose errors that violate established clinical and regulatory guidelines. Question 23. At a busy gynecologic oncology center, Dr. Rivera is performing intracavitary brachytherapy for MS. Monroe, 48-year-old patient with cervical cancer. During the procedure, you are tasked with assisting in the insertion of the brachytherapy applicators. While preparing the patient and verifying the applicator positioning via imaging, you notice that the applicators may not be optimally aligned with the intended treatment volume due to anatomical variations. given that precise applicator positioning is essential for achieving the planned dose distribution and avoiding unnecessary exposure to nearby organs at risk. What should be your immediate response according to the institutional protocols and guidelines from the American Brachytherapy Society? A. Proceed with the insertion as scheduled, trusting that the treatment planning margins will compensate for any misalignments. B. Immediately pause the insertion process, notify the brachytherapy specialist, and verify the applicator alignment with updated imaging before proceeding. C. Adjust the applicators based solely on your clinical judgment without further imaging feedback. D. Continue with the procedure and plan to modify the treatment plan if needed. Answer. Correct answer. B. Explanation. Brachytherapy procedures rely heavily on precise applicator placement, and any deviation can result in significant dose distribution errors. Following the American Brachytherapy Society guidelines, it is critical to confirm applicator position with current imaging before proceeding. Option B ensures that the potential misalignment is addressed immediately, thereby optimizing the treatment outcome and minimizing risks to adjacent tissues. Options A, C, and D fail to incorporate the necessary verification and adjustment process that is essential for safe and effective brachytherapy. Question 24. In the midst of a prolonged course of intensity-modulated radiation therapy (IMRT) for head and neck cancer, Mr. Ortiz, 60-year-old patient, begins to exhibit moderate to severe mucositis and skin reactions. His treatment plan, designed with strict dose constraints, is now being challenged by anatomical changes and the cumulative effects of radiation on sensitive tissues. The interdisciplinary team, including nutritionists, support care and radiation oncologists, is called upon to reassess his ongoing therapy. In this scenario, what strategy best reflects the current consensus on modifying treatment to enhance both the therapeutic ratio and patient comfort while adhering to established guidelines, e.g. ARRT protocols? A. Continue with the current treatment plan without alterations, solely increasing pain management medications. B. Interrupt the treatment entirely and convert to palliative regimen without further reassessment. C. Collaborate with the entire care team to reassess the treatment plan, potentially modify dose constraints using an adaptive approach, and integrate supportive care measures tailored to manage acute side effects. D. Make minor adjustments to the radiation beam angles without further consultation, assuming this will relieve the side effects. Answer. Correct answer. C. Explanation. Managing acute treatment side effects requires a multifaceted approach that balances effective tumor control with patient quality of life. ARRT guidelines and supportive care standards advocate for an interdisciplinary reassessment when significant side effects occur. Option C correctly emphasizes team collaboration, adaptive planning, and the integration of supportive care measures to adjust treatment parameters accordingly. Options A, B, and D do not provide a comprehensive solution and risk further compromising both treatment efficacy and patient well-being. Question 25. Dr. Young oversees a daily treatment schedule that includes using a linear accelerator for high-precision IMRT treatments. Today, as you prepare Mr. Kim, a 57-year-old patient with head and neck cancer, for his treatment, you observe that the machine's gantry positioning appears slightly off from the planned angle. Given the precision required in beam delivery for critical regions, such deviations may impact the conformity of the dose distribution, potentially increase exposure to critical structures. Considering manufacturer protocols, OPAM quality standards, and patient safety considerations, what is your best response to address this issue prior to proceeding? A. Immediately notify the clinical supervisor and medical physicist, recheck the machine's calibration, and confirm that the gantry position is corrected before beginning treatment. B. Adjust the patient's position slightly to account for the error without halting the machine's operation. C. Document the discrepancy and continue the treatment, assuming the error is within an acceptable threshold. D. Request that the treatment be completed on different day when the machine is recalibrated without engaging in further immediate troubleshooting. Answer. Correct answer. A. Explanation. The precise operation of a linear accelerator is critical to ensuring accurate dose delivery, particularly in complex areas such as the head and neck. Adhering to OPAM and manufacturer quality assurance protocols, any deviation in machine calibration must be addressed immediately before treatment. Option A ensures the discrepancy is properly managed in collaboration with the clinical supervisor and the medical physics team. Options B, C, and D risk compromising treatment quality and patient safety by failing to fully resolve the issue in a timely manner. Question 26. A leading radiation oncology center, Dr. Lewis, is overseeing the treatment of Esther Martinez, a 65-year-old patient with pancreatic cancer who is scheduled to receive series of fractions using advanced stereotactic techniques. During the verification of treatment parameters, you notice that the dosimetric units in the treatment plan, grade GI for absorbed dose and SIVA SB for effective dose, are not consistently reported across different sections of the plan. The accuracy of these measurements is essential not only for ensuring the prescribed dose is delivered, but also for monitoring potential overexposures as per ARRT principles and NRC guidelines. What is the most appropriate course of action to resolve these discrepancies before proceeding? A. Assume that minor reporting errors are inconsequential and proceed with treatment without further clarification. B. Adjust the treatment plan manually to match one dosimetric unit without verifying proper conversion factors. C. Continue with the plan and schedule post-treatment audit to address the unit inconsistencies retrospectively. D. Halt the treatment and confer immediately with the medical physics team to review and correct the dosimeter. Unit reporting, ensuring consistency with current dosimetry standards and guidelines. Answer. Correct answer, D. Explanation. Consistency in dosimetric unit reporting is critical for accurate treatment delivery and safety monitoring. The NRC and the LARA principles require that discrepancies in dose reporting be resolved prior to treatment. Option D is correct as it calls for an immediate review and correction with the medical physics team to ensure that all measurements adhere to the prescribed standards. Options A, B, and C risk misadministration of dose and potential patient harm due to unresolved inconsistencies in treatment documentation. Question 27. During a routine daily setup, you are assisting Dr. Finch with the treatment of MS. Delgado, a 50-year-old patient receiving conformal radiation therapy for breast malignancy. The pre-treatment procedure involves strict verification of the patient's identity through multiple channels, including wristbands, electronic records, and visual confirmation, along with comprehensive review of treatment parameters such as beam energy and field size. On this date, you notice that while the patient's identity appears to be consistent, there is minor but significant discrepancy in the documented beam energy between the treatment planning system and the delivery console. Given the strict regulatory guidelines from the Joint Commission and ACA on patient identification and treatment accuracy, what is the correct response? A. Continue with treatment, assuming that the discrepancy is minor clerical error that will not affect dose delivery. B. Resimulate the treatment immediately without consulting any team member to correct the error on the fly. C. Halt the treatment process, inform the radiation oncologist and the medical physicist, and verify that the beam energy settings are corrected to match the treatment prescription before proceeding. D. Document the discrepancy, quality assurance purposes, and proceed planning to resolve the error at later time. Answer. Correct answer, C. Explanation. Ensuring accurate patient identification and treatment parameter verification is non-negotiable in radiation therapy. The Joint Commission and ACA guidelines emphasize immediate resolution of any discrepancies to safeguard patient safety. Option C is correct as it mandates an immediate halt and interdisciplinary verification, thereby maintaining strict adherence to safety protocols. Options A, B, and D undermine patient safety by failing to address the discrepancy in a timely and systematic manner. Question 20. Dr. Wells is evaluating the treatment plan for Esther Norris, a 54-year-old patient with complex head and neck tumor. The current plan is based on IMET techniques designed to achieve high conformality while sparing critical structures like the spinal cord and salivary glands. However, during detailed review of the dose distributions and isodose curves, you notice that the high-dose region is bordering sensitive tissue in manner that could elevate the risk of toxicity. As the treatment planning team debates alternative beam arrangements and modulation strategies, what course of action best aligns with state-of-the-art treatment planning guidelines and radiobiological principles? A. Maintain the original plan and proceed, assuming that the slight overexposure to sensitive tissue is acceptable within current clinical tolerances. B. Reassess the beam angles and modulation parameters in collaborative session with the dosimetrist and radiation oncologist, then adjust the treatment plan to optimize both target coverage and organ at risk sparing. C. Broccoli switched from IMRT to less conformal 3-conformal approach with reassessment, believing it inherently reduces the risk of toxicity. D. Increase the target volume margin substantially to compensate for the observed risk without adjusting beam characteristics. Answer. Correct answer. B. Explanation. Modern treatment planning for head and neck malignancies demands a delicate balance between effective target dosing and sparing of critical structures. Guidelines from the OPPM and NICRU recommend a collaborative reassessment of beam arrangements when isodose distributions jeopardize sensitive structures. Option B is the correct course of action because it involves a multidisciplinary review and targeted modifications to achieve optimal dose conformity while minimizing toxicity. Options A, C, and D either disregard the risk or overcompensate without addressing the underlying planning challenges. Question 29. Ms. Jackson, a 49-year-old patient undergoing concurrent chemoradiation for locally advanced gastrointestinal tumor, has begun to experience marked gastrointestinal upset and dehydration, impacting her ability to tolerate the planned radiation schedule. Given the critical importance of patient support and the potential for acute toxicities to compromise both treatment delivery and overall outcomes, the interdisciplinary team, including radiation oncology, nursing, nutrition, and supportive care services, is prompted to reassess her care plan, considering the SEN guidelines and best practices for integrating supportive care in oncology treatments. What is the most suitable action to take in order to manage her side effects while maintaining treatment efficacy? A. Continue with the prescribed treatment regimen without modification, relying solely on standard antiemetic protocols. B. Collaborate with the supportive care team to adjust the treatment schedule and integrate enhanced nutritional and hydration support, as well as modify medications based on her current condition. C. Immediately suspend the radiation treatment until her gastrointestinal symptoms completely resolve, regardless of progression. D. Switch the patient to an alternative radiation modality without addressing the supportive care needs, assuming the change in modality will reduce side effects. Answer. Correct answer. A. Explanation. No. Please see correction below regarding the correct answer choice and explanation. After thorough review, the correct answer is actually B. Integrating supportive care is essential in managing acute treatment toxicities. SEN guidelines emphasize that adjustments to both the treatment schedule and supportive interventions, such as nutritional and hydration support, are imperative when patients experience significant side effects. Option B represents an interdisciplinary approach that addresses her symptoms proactively while ensuring the continuity of treatment. Options A, C, and D do not provide a balanced solution to manage side effects without compromising treatment efficacy. Question 30. At a comprehensive cancer center, Dr. Mitchell is responsible for overseeing the radiation safety program during a busy treatment day, which involves multiple advanced modalities including IMRT, VMAT, and brachytherapy. Mr. Daniels, a 68-year-old patient, is receiving treatment from linear accelerator in room that is routinely monitored for stray radiation. During routine survey, you observe that certain areas around the control console show slightly elevated radiation levels compared to previous surveys. As the facility adheres to the stringent protocols established by the NRC and state radiation safety guidelines, which of the following actions addresses these elevated levels while ensuring the ongoing safety of both staff and patients? A. Continue operations without modifications, assuming the levels are within accepted tolerances. B. Immediately evacuate the treatment area for full safety shutdown without further investigation. C. Adjust the treatment parameters to minimize beam on time in the affected areas without conducting additional surveys. D. Halt further radiation use in the affected area. Perform an in-depth radiation survey with the radiation safety officer and physicist, and adjust shielding or procedural protocols as necessary to bring the stray radiation levels within regulatory limits. Answer. Correct answer. D. Explanation. Ensuring an optimal radiation safety environment is essential, particularly when stray radiation levels are observed above previously recorded baselines. Regulatory guidelines from the NRC and state authorities require immediate and thorough investigation of any deviation from normal survey results. Option D is correct as it emphasizes immediate cessation of operations in the affected zone, followed by the comprehensive survey and corrective action planning in collaboration with radiation safety experts. Options A, B, and C either neglect proper investigation or do not address the root cause of the elevated measurements, thereby potentially jeopardizing staff and patient safety.